Let's go. This is ECG. It is Faravee's classroom. We actually go through the ECG in the medical practice written by the Professor Abdullah. We are here from Jaisman Medi Educare. Today's lesson in ECG class is T wave and U wave. This is ECG U wave. Look at this ECG tracing. This is the P wave. This is the Q, this is R, this is S, this is ST segment, and T wave and U wave. Look at this T wave. It follows the S wave and ST segment. Tip is rounded. Look at closely. Its height is more than 1, 2, greater than 2 millimeter in height. It actually represents the ventricular repolarization in chest lead and in standard lymph node. It is standard lymph node, it is less than 5, and chest lead it is less than 10 millimeter. Usually it is more than 2 millimeter in height. Now see the normal characteristics of T wave. T wave characteristics of normal T wave. It represents the ventricular repolarization, follows the S7 ST segment, upright in all lead except aviar, usually more than 2 millimeter in height, may be normally inverted in V1 and V2, that means juvenile T wave, normally not more than 5 millimeter standard lead, 10 millimeter in chest lead, and it is taller in V6 than V1 and taller in lead standard limited 1 than standard limited 3. Minimum 1/8, not 1/8, but less than 2/3 of the amplitude of the corresponding R wave. Tip of the T is smooth rounded. Look at this ECG tracing. Lead 1 and lead 3. Lead 1 is T waves larger than the lead 3, and V1, look at the V1, it is inverted. Normally T wave is inverted in V and V2. And aviar, look at the aviar is T wave inverted. Now look at the V1 and V6. In V6, T wave height is more than V1, and minimum height is 1/8, and less than, more than, at least 1/8, but less than 2/3 of the amplitude of the corresponding R wave. Look at another ECG tracing. Here is the lead 1 standard bipolar lymph node is lead 1 and lead 3. And look at the V1 and V6. Look at the aviar. Now we go through the abnormality R wave. It's inverted R wave. Well, first of all, inverted R wave, symmetrical, asymmetrical. Asymmetrical inverted. T wave is ventricular hypertrophy with strain pattern, myopathy, hypertrophic cardiomyopathy, digoxin toxicity. Now the abnormality T wave is, first one is inverted, asymmetrical and symmetrical T wave inversion, tall peak dented T wave, small flattened T wave, camel hump T wave, abnormal T wave, and non-specific T wave change. Now look at the inverted T wave. This is divided into two parts, symmetrical and asymmetrical. And asymmetrical T wave is ventricular. In which condition we found in asymmetrical T wave? Ventricular hypertrophy with strain pattern, hypertrophic cardiomyopathy, digoxin toxicity. And in which condition is usually get asymmetrical T wave? Is ischemic heart disease, myocardial infarction, and myocardial ischemia. Now look at the ECG tracing. Look at the amplitude. It is more than 2 millimeter in height and rounded. Normal morphology and abnormal morphology is upright, normal upright, tall, tented peak, inverted, biphasic, and notch. Now another diagram of abnormal T wave. Look at this T wave inversion, inverted T wave. This is the symmetrical T wave. This is arrowhead. Both arm of the T wave, inverted T wave, is identical or symmetrical or same. Now the asymmetrical is down slope and upward. There is not same or identical. Now causes of the T wave inversion: myocardial ischemia, infarction, subendocardial myocardial infarction, ventricular ectopic, ventricular hypertrophy with strain pattern, acute pericarditis, cardiomyopathy, mixed edema, bundle branch block, WPW syndrome, subarachnoid hemorrhage, pulmonary embolism, drug, distylis, imitin, phenothiazine, lithium, Physiological. Look at this, the physiological. Smoking, anxiety, anorexia, exercise, after meal, and glucose. Now recapitulate. Causes of T inversion: myocardial ischemia and infarction, myocardial ischemia, myocardial infarction, subendocardial myocardial infarction, that's called the non-QA myocardial infarction, ventricular ectopic, ventricular hypertrophy strain pattern, acute pericarditis, cardiomyopathy, myxedema, bundle branch block, WPW syndrome, subarachnoid hemorrhage, pulmonary embolism, drugs. Physiological, that heart related is the myocardial ischemia, infarction, subendocardial myocardial infarction, ventricular ectopic, ventricular hypertrophy, acute pericarditis, cardiomyopathy. Now the myxedema, bundle branch block, WPW syndrome, subarachnoid hemorrhage, pulmonary embolism, and drug. And the physiological. Now look at the tube inversion. In tube inversion, we found the symmetrical and asymmetrical. We already mentioned the symmetrical tube inversion is found medically, mainly myocardial ischemia and infarction. Look at this, the myocardial ischemia. The two arm of the T inversion is the same or identical. Now the left ventricular hypertrophy strain pattern. Asymmetrical tube inversion. What do we already know the causes of asymmetrical tube inversion? Asymmetrical tube inversion, ventricular hypertrophy strain pattern, hypertrophic cardiomyopathy, digitalis toxicity. Now ventricular hypertrophy strain pattern, asymmetrical tube, that is down slope and up slope. These are not the same or identical. Now the arrhythmogenic right ventricular cardiomyopathy is one type of cardiomyopathy. Look at the symmetrical tube inversion. In cardiomyopathy, the arrhythmogenic right ventricular cardiomyopathy, this is the epsilon wave, and that's followed by the symmetrical tube inversion. Causes of tall tented T wave. Hyperkalemia, hyperacute myocardial infarction, acute true posterior myocardial infarction, prinzmetal angina may be normal in some African and Asian. Now this is, previously we go through the causes of T inversion. There is a physical tube inversion, that is a tall and thick tube. There is also normal and physiological in some African and Asian. What are the causes of tall tube? Hyperkalemia, hyperacute myocardial infarction, acute true posterior myocardial infarction, prinzmetal angina may be normal in some African and Asians. Now look at this ECG tracing. Tall, tented in the chest lid. Look at the chest lid. Here it is more than 10 millimeter in height. That's called is tall. That is the arrowhead. This is called the peak and tented. Look at this ECG. There is a V2, V3, V4, V5. What are we actually normally seeing? V6 is more than V1. Here is V4 to V5. V4 is a tall T wave. It is normally physiological in African and Asian. Causes of small flat T wave: hypokalemia, hypothyroidism, and pericardial effusion. Causes of small and flat T wave: hypokalemia, hypothyroidism, and pericardial effusion. Now camel hump T wave. What is the camel hump T wave? Fusion of the T wave with U wave. In which condition we find the camel hump T wave? Hypokalemia and nodal rhythm. Hypokalemia and nodal rhythm. Abnormal T wave balance. What this means is normal T wave is V1 is upright and larger than V6. That is the total opposition of normal T wave, in which in first phase of the first phase we go through the normal characteristics of the T wave. In that phase we already we have already known that T wave in V6 is larger and upright than V1, and there is the opposite incidence. The T wave is V1 is upright and larger than V1. This is called the abnormal T wave balance. That means the underlying cardiac disease present. Non-specific T wave change. What is done with the non-specific T wave change? General flattening of the T wave with normal QT interval. Now what is the juvenile T wave pattern? Normally T wave inversion is V1, V2. It may extend up to the V3 and V4. Not associated with symmetrical T wave inversion or deep T inversion. It's common in children, young adult, in female less than 40 years. Frequently, it is associated with the sinus arrhythmia and high left ventricular voltage. Now look at this. This is one ECG tracing, then the second ECG tracing, and third, the first, second, and third. There is a 3 ECG tracing paper in the chest lead, V1, V2, and V3. Look at here is the 4 years old teen version, and that's the 13 years old Caucasian male, that teen version, and there is a 16 years old adolescent, there is a teen version. This is called the juvenile, not symmetrical, not deep. It is associated with sinus arrhythmia and high left ventricular voltage. Now look at this, the persistent juvenile pattern. It is if juvenile TOF is present in adult, this is called the persistent juvenile TOF pattern. Look at the chest lead, V1, V2, V3, V1, V2, and V3. This is the TOF inversion. That's called the persistent juvenile pattern. Now we go to the U wave. U wave usually follows the T wave. Look at the U wave. U is height more less than 1.5 millimeter. It is usually upright according to the T equals upright. Follow the T wave. What does it mean? It means the slow repolarization of interventricular septum, papillary muscle, or Purkinje fiber. Exact cause is known why U wave is found in ECG. Characteristics of U wave. It follows the T wave, may be present in normal ECG. It normally is smaller in the same direction to the preceding T wave. It presents a slow repolarization of interventricular papillary muscle and Purkinje fiber. It is best in chest lead, B2 to B4, normal amplitude. What are the characteristics of normal U wave? It is usually follows the T wave. Normally present in normal ECG. It is smaller and the same direction of the preceding T wave. It actually represents the slow repolarization of interventricular system, interventricular septum, papillary muscle, or Purkinje fiber, but actual genesis of it is still controversial. It's better seen in chest lead, V2 to V4. Normal amplitude is 1.1 millimeter. If it is more than 1.5 millimeter, it is called the prominent U wave, prominent large U wave. What are the abnormality U wave? Inverted U wave and prominent U wave. Look at these pictures. Look at this ECG tracer. U wave, T wave, U wave is normal. That's not the normal. The T wave amplitude is small and flattened, followed by this is the significant U wave. Look at this U wave. This is more than 1.5 millimeter. This is the abnormal. And it is a prominent U wave. Look at this, is a flattened, small, absent U wave. This is a prominent U wave. Look at this is tracing. It is inverted U wave, inverted U wave, inverted U wave. What are the abnormality U wave? Is inverted U wave and prominent U wave. What are the causes? Causes of inverted U wave: ischemic heart disease, left ventricular hypertrophy with a strain pattern, particularly the hypertensive heart disease. Look at this hypertensive heart disease. Ischemic heart disease, left ventricular hypertrophy with strain pattern, particularly the hypertensive heart disease. What are the prominent U wave? In which condition you get the prominent U wave? It is more than 1.5 millimeter in height. Hypokalemia, hypercalcemia, hypothyroidism, bradycardia, ventricular hypertrophy, drug, phenothiazine, quinidine, digitalis, and cerebrovascular accident may be normally seen usually, but it is not more than 1.5. Normal ECG there, in normal condition, U wave may be present. This is the normal phenomena. If it is height less than 1.5, it is more than 1.5, it actually means that prominent U wave and pathological condition. And look at this. U wave is probably only important if it follows the flattened, small, flattened T wave. What are the significance of the large U wave? The patient is found to develop torsade pointless tachycardia. U wave. In which condition we get the U wave? Look, hypokalemia, bradycardia, hypercalcemia, hyperthyroidism, severe drug, ventricular hypertrophy, bradycardia. And significance of the large wave, this patient is found to develop torsion pointes tachycardia.